Okay.
All
This
right.
meeting is being recorded.
Okay, thank you for letting us know it's being recorded. Okay, I am going to share my screen.
Yeah, so I just want to do a quick intro. Welcome everybody, and welcome Jen. If you want to just introduce yourself, you can put the screen up there too. But welcome to this talk today, everyone who's joining us either live or on the recording.
So my name is Jen Gillick. I'm pleased to be here. Thank you for inviting me to share information about Parkinson's and what we do as an organization. I am the program director at the Northwest chapter of the American Parkinson Disease Association. It is a mouthful. We call ourselves APDA because that's way easier to remember sometimes, or people get the, anyway. So I'm the program director here. I will be talking about, we're going to do kind of a little bit of Parkinson's 101. We'll talk about the resources available to individuals and families impacted by Parkinson's. And as I'm going through this, if you have a question, please feel free to interrupt me and ask. I'm going to have a PowerPoint. I'm going to share a lot of information, but if something pops into your head, please, you can just ask, or you can type it in the chat, or whatever you want. My colleague Heidi just hit herself, but she just started at our organization, and so she is here to listen and learn. She just waved because she's been in her job a whole 4 days. Wait, 2 weeks. 2 weeks. Time flies. So yeah. So I'm going to share my screen, and we will get going. Okay, and you all see a little thumbs up that you can see just my presentation.
Yep.
Okay, yep. Great. I have to move all my faces out of the way somewhere. Okay. So like I said, I am from American Parkinson Disease Association. Up on this slide is our mission as an organization. And that is really about providing support, education, and research that really helps everyone live life to the fullest. So we want people with a diagnosis of Parkinson's, we want to provide them resources and support so they can live their best quality of life. Our tagline is strength in optimism and hope in progress. They're not really, they are words that live under our logo, but they really are kind of the credo with which we live by. We want people who are diagnosed with Parkinson's to live an optimistic life, that they have empowerment to affect their quality of life. And there's hope and progress in the research that's going on. So today I'm going to give a brief overview about Parkinson's and how our organization serves this community. So these bullet points are a little bit about an overview of what I'm going to talk about. It's also an overview on how to manage well with this disease and how we as an organization, APDA, can help with that, managing well. Little disclaimer, do remember that any medical information is for the purpose of information, and I am not a physician. Some people sometimes think I play one on a daily basis, but I'm not going to give you medical advice. I will put you in the direction of your healthcare provider, but I will give you general information about Parkinson's. Before we begin, I do want to highlight a few important things about Parkinson's. First of all, there has been a tremendous amount of progress in the understanding about Parkinson's in over the years. And there's been a lot of great developments in the treatments for PD. In addition, Parkinson's disease is highly individualized. I personally like to call it a designer disease. Every single person has their own couture version of Parkinson's disease. There are some similarities with folks, but if you've seen one person with Parkinson's, you truly have seen one person with Parkinson's, often described as a snowflake disease. So it's just important to remember that as we go through this. Also, that a diagnosis of Parkinson's disease impacts not just the person, and as you guys probably know this from your work, it also impacts their family, their social networks, and the community at large. Specialized care and a really good healthcare team leads to the best quality of life for individuals living with Parkinson's. It really is a team approach that might include a neurologist, a physical therapist, a speech therapist, a psychologist, a social worker, an occupational therapist. There can be a whole host of people in this team approach, and I'll talk a little bit about that today. So what is Parkinson's disease? Parkinson's is a brain disorder that affects a person's ability to perform common daily activities. Symptoms of Parkinson's are generally divided into two categories: motor symptoms, which are those that affect movement. A lot of times the things that you can see with your eye are the motor symptoms. And then the non-motor symptoms that don't involve movement, but there are impacts to sleep, constipation, depression, fatigue, anxiety, a whole host of other things that are kind of under the surface that we'll go into more detail later. So the substantia nigra, which is pictured here, is an area that's kind of deep within your brain, and it communicates with other areas of the brain, and it uses a brain chemical called dopamine. Parkinson's is a dopaminergic disease, meaning those with Parkinson's are not getting enough dopamine. Proper dopamine signaling in this part of the brain is critical in normal movement because dopamine is responsible for movement and coordination. So it's what helps you move smoothly through the world. And so in Parkinson's, the cells of the substantia nigra, this little part in the brain, degenerate. And so that they lead to a lack of dopamine that's produced and signaled throughout the body. And then that leads to difficulty with movement. There are lots and lots of other nerve cells in the brain that degenerate as well with Parkinson's, and those we think cause a lot of those non-motor symptoms, but dopamine is definitely a huge part of what causes all these symptoms with Parkinson's. And a lot of what, I'll get into medication, but a lot of what medication is about is giving people more dopamine. So the motor symptoms of Parkinson's, these are the things that we can see with our eyes. There are 4 primary motor symptoms of Parkinson's disease, and they're used to diagnose Parkinson's. So they can be remembered with TRAP. So you get trapped in Parkinson's. I don't know if I want to say that, but I did. So they're tremor, rigidity, akinesia or bradykinesia, and postural instability. So I'll go over those a little briefly. So tremor is what's called a resting tremor versus an action tremor, which is seen with something like essential tremor, which is a pretty common disorder. A resting tremor, well, it's a tremor at rest. So you can have your arm at your side and your hand or your arm may be tremoring. Some folks get an internal tremor. Some folks have like a tremor of their leg, but it really is a resting tremor versus an action tremor, which is I go to reach for my cup of coffee and I'm tremoring as I reach for my cup of coffee. That's what that movement initiation causes the tremor versus just being at rest. Tremor, which is often the first thing people think about with Parkinson's disease, is not required for diagnosis. And in fact, not everybody with Parkinson's, remember I said it was a snowflake disease, not everyone with Parkinson's has tremor. In fact, one of the recent studies is they studied 100 people with Parkinson's disease diagnosis, and 69% had tremor at the onset of their disease when they got diagnosed, and then it went up to 75% had tremor at some point during their disease. So there's a good 20 to 25% of people who tremor is not part of their Parkinson's. Rigidity is the next one, and this is kind of a constant stiffness or passive movement of the joint. So when this is diagnosed clinically in a doctor's office, they often move like somebody's hands, and it does this thing called cogwheeling. So it's like kind of stopping and starting, stopping and starting, stopping and starting. And that's like the rigidity that is caused by Parkinson's. This can produce a feeling of stiffness or cramping. It can be painful for some people. Rigidity, some people will get diagnosed with some kind of orthopedic condition. And then they'll figure out, oh, that's not frozen shoulder. That's actually the rigidity caused by Parkinson's. So that's the rigidity of Parkinson's. It's like this stiffness. And then there's akinesia or bradykinesia. So akinesia is a decreased ability to initiate movements. It translates into these slow and small movements. Bradykinesia means small movement. So this is a necessary thing to get a diagnosis for Parkinson's, but it's not sufficient. You have to have more than just bradykinesia to get a diagnosis. So it's a little complex to diagnose this, but everybody has this slowness of movement. So this can be seen in short shuffling steps. It can be seen in a masked face because your face is not moving. That's that like slowness of like being able to raise your eyebrows, something like that. Hesitations in actually getting going. Like, okay, I'm ready to get going. And then I have a hesitation to do that. That's what this bradykinesia, akinesia is. And then there's postural instability. So this is, a loss of balance reflexes. This can lead to postural changes. Stooped posture can be quite common in Parkinson's. It can have walking problems, balance problems. Actually, falling backwards is something with this postural instability that people with Parkinson's, it's like this retropulsion. And then there's, gait problems. And it may be very slightly impaired by this gait and walking very early on in diagnosis. There can be a decrease in arm swing, shuffling steps. As the disease progresses, because this is a progressive disorder, walking issues can be more pronounced in sort of the later stages. So those are the motor symptoms of Parkinson's. And then there's the non-motor symptoms. This is a really common slide to see in a Parkinson's presentation, this like iceberg thing, because the motor symptoms are so visible, but the non-motor symptoms are totally beneath the water and they're not visible, but they can be sometimes when you speak to somebody, even more problematic than the motor symptoms, these non-motor symptoms. There's a whole host of them. And because everybody's a little bit different, not everyone will have every single one of these motor symptoms. And the severity of these motor symptoms is very different as well per person. They're typically, these non-motor symptoms are three categories. The neuropsychiatric that you see here, the sensory, and the autonomic. So the neuropsychiatric, depression, issues with sleep, those two of this can often be things that folks have been dealing with far before their diagnosis with Parkinson's. Because for many people, what sends them to the doctor to get diagnosed with Parkinson's is an appearance of a motor symptom. And that happens when less and less and less and less of your dopamine is being produced. So these cells in your brain are dead and they've been causing problems underneath the surface, like sleep issues and depression issues. And then you suddenly get like a tremor or you feeling really stiff or something like that. So, so these can be pre-diagnosis symptoms. So mood, sleep, thinking are psychiatric. There can be some cognitive impairment, particularly like in executive function. There can be some apathy and anxiety with Parkinson's. The autonomic nervous system can be impacted. These are things that you don't have to think about, like your blood pressure, like your heart rate, like the emptying of your bowels, urinary stuff. So these aren't controlled consciously, and they can be impacted with Parkinson's. And then there's some sensory disturbances, visual disturbances, like visual hallucinations, sometimes some delusions. These things often appear later on in Parkinson's in more the advanced stages. There can be some pain with Parkinson's, and then loss of sense of smell, which is actually one of those precursors to diagnosis for many people. And then there's other most common that aren't on here, but these are kind of this host of non-motor symptoms. And I will say, from the perspective of somebody who's been working with Parkinson's for a long time, these can be, I hear a lot more complaints about this, and also there aren't as many medications to treat these non-motor symptoms that are specifically for Parkinson's non-motor symptoms. So it's a lot harder to treat some of these non-motor symptoms. Yeah, so statistics. Parkinson's is the second most common age-related neurodegenerative disorder. It is growing in size. They expect the instances of Parkinson's to double by 2040. This slide was actually put together before the pandemic. So it's interesting that we're all very familiar with a pandemic, but researchers are very concerned that if we don't make some great strides in research, this disease could get to pandemic proportions, and that's going to have impacts like in all stratas of society. There are about 1 million people in the US with Parkinson's, and men are 1.5 times more likely than women. Factors leading to this increase are longevity in life. We are just living longer. Weirdly enough, declining smoking rates. I'm not telling you to go out and start smoking, but nicotine, cigarette smoke is neuroprotective. Who knew? But it is. Smokers are less likely. It's very interesting. And then increased industrialization is actually the one that is the most concerning, as far as like the amount of toxins in our environment that might be leading to this increase in people with Parkinson's. The average age of onset of Parkinson's is age 60, but an estimated 10 to 15% of people are diagnosed before the age of 50, which is called young onset Parkinson's. And so these are people in their prime earning years. And I am seeing more and more people just anecdotally coming in with young onset Parkinson's, whether they're just finding us, or I'm not really sure. I don't know if this has gone up from 10 to 15%. So that is some statistics. In 2019, they did a study that calculated the economic burden of Parkinson's. So when I said this is growing, this is part of the impact of that. In the US, we spend about close to $52 billion every year on Parkinson's disease care. About half of it is shouldered by the federal government through, Medicare, Medicaid, those kind of programs, and about half is shouldered by the people with Parkinson's in the form of like copays, lost wages, out-of-pocket expenses, those kind of things. So it's kind of an expensive disease, and the funding of research into the cure and better treatments has really been flatlined over the last 15 years. So it hasn't really kept up with the growth of Parkinson's. And that's actually something that is really in the advocacy world right now. A big focus is, how do we increase funding for research? And there's actually some really exciting legislation going through Congress right now about caring for people with Parkinson's and increasing research funding. So it's kind of exciting. We'll see what happens with it, but we're hopeful. What causes Parkinson's? So the risk factors for Parkinson's, there is a male to female ratio of about 3 to 2. So more males are diagnosed traditionally with Parkinson's than women. There are environmental, it's kind of a combination of environmental and genetic factors. They don't 100% know what actually causes Parkinson's. Over 20 genes have been identified that are associated with Parkinson's. Most people do not have a genetic mutation who have Parkinson's. Having a first-degree relative modestly increases the risk, but just because your relative has Parkinson's doesn't mean you're going to get Parkinson's. So as we understand more about like the genetic component, we'll be able to increase our understanding on who and prediction on who's going to get Parkinson's. But there really has to be this trigger from the environment that explodes these genetics into Parkinson's is what is the most, that's what the research is pointing to. So certain environmental toxins, such as pesticides, there's a big movement in the advocacy world for 3 pesticides to get banned. Paraquat, which is all the evidence is like super strong on paraquat really increasing Parkinson's risk. Is still legal in this country. It's banned in many, many other areas of the world. So there's a big movement, and it's actually the EPA is looking at it right now to see about banning it. There's a chemical called TCE that was just banned, partially due to Parkinson's advocacy, which is great. So pesticides do increase risk. The veterans population, particularly those who are in Vietnam and exposed to Agent Orange, a pesticide, the veterans population has a much larger proportion of Parkinson's than the general population. Traumatic brain injury can increase risk as well. If you think about Muhammad Ali, he was constantly hit in the head and he developed Parkinson's. And then heavy metal exposure, kind of going with the toxin thing. So it is important to note that genes and environment really work together to affect PD risk. And it may be more significant with someone with a particular gene mutation, although genetic testing is not commonly recommended. Like if a parent wants to test their kid, it's not really gonna, there's no surefire thing that their child is gonna get Parkinson's because there's all these different factors. So there's still a lot to be studied here, would be the upshot of this slide. So when someone has Parkinson's, on average, people with Parkinson's can really expect a nearly normal lifespan. Trajectory of their disease stays roughly constant in early to middle stages. In fact, post-diagnosis, sometimes the motor symptoms may even get better or slow down because they know what to do with it. And there are things that you can impact in your life to make your progression slow down. Advancing age rather than disease duration is the most important predictor of progress. So those with young onset Parkinson's, like my friend Jeannie has been living with Parkinson's for 35 years. And, you know, she is still active and involved, and, you know, and she's been living for 35 years with Parkinson's disease. Does it impact her life? Absolutely. And she's had to change some of, you know, the way that she was doing things from 30 years ago. But it's a pretty normal lifespan. So this slide does illustrate the most widely recommended treatments. Medication definitely is one of them, and I'll go through that a little bit. I'll go through all of these. Therapy, so allied health professionals, physical, occupational, speech therapy. And then there's some surgical options to treat Parkinson's, and I'll discuss all of these. So medications, there is no cure for Parkinson's, or not yet, although it's being studied and it's getting there, we'll see. There is no pharmaceutical way to stop progression. It is a progressive neurological disease. You know, the cells in the brain are dying. So a lot of research is focused on finding ways to protect the neurons in the brain from degenerating. It's not yet available, but there is a lot of promise in this area. But right now, available treatments are really about helping control the motor symptoms of Parkinson's. So a lot of the pharmaceutical treatments are really about controlling symptom management so that people can live their best quality of life. So for the motor symptoms, the medications are really about either giving people more dopamine or opening up the pathways so the dopamine that you already have still produced in your brain can get out to your body. And the goal of medication management is to really get the right dose without too many side effects. And it can be very polypharmaceutical. There can be a number of medications that are working together to do this. Regular adjustments to medication dosing and timing is really key. So working with a healthcare professional who knows all about all the medications, because everybody's response to medication is a little bit different. Everybody's gut biome where the medication needs to be processed is different. So there really has to, this individualized care with it is got to be talked about and worked on. This slide shows you the most common classes of medications for Parkinson's disease. The gold standard of Parkinson's disease treatment is this thing called levodopa. It's actually called carbidopa-levodopa. It has been around since the 60s. It was a game changer in the Parkinson's world. People couldn't move, and levodopa helped that. So carbidopa-levodopa is given together because carbidopa makes the nausea of levodopa go away. And it's a very standard treatment. It really still is the gold standard since the 60s. And there's lots of formulations that exist of getting levodopa into the body. So there's lots of different ways that they've figured out how to do that. And then there's all these other things. I said it was a very polypharmic approach. And treatment is really based on what symptoms are bothersome, the age of the patient, and then other comorbidities that folks may be living with. A little note about medication scheduling. For many people with Parkinson's, almost unless they're in the very, very early stages, taking their PD medications on time is very important. This can be particularly challenging if someone with Parkinson's gets admitted into the hospital, because the knowledge varies so greatly with medical staffing in the hospital. But getting medication on time is really important because it can greatly affect how somebody feels. Remember, I said it's about controlling symptoms. So if the medication isn't on board in your body, then you are getting greater symptoms. And so that can be very troublesome for folks. So we do recommend people like setting timers. We have a symptom tracker. There are possible food interactions. So kind of keeping track of these things and how the medications on board are important. We have an app for this. APDA has a symptom tracker app. Oftentimes I recommend to people, maybe not every day, but maybe 2 weeks before you see your doctor, keep a diary, track how you're feeling, when you take your medication, what you've eaten, that kind of thing, so that you can best communicate with your doctor what's working and what hasn't, so they can tweak whatever medication it is and how it's being dosed. So that's a note on that. Rehab services are an integral, that's the way we say it, I think, component of Parkinson's treatment. Physical therapy, occupational therapy, and speech therapy. Physical therapy, I often talk to people about prehabilitation. Get in to see a physical therapist before you start having any kind of significant problems. Working on strength, balance, walking, that is going to help someone live much better with Parkinson's. Telemedicine has been very kind to Parkinson's. With COVID, this increase in the ability to do telemedicine. So seeing a speech therapist or a physical therapist or even a neurologist via Zoom is possible now, which is pretty great because they can watch somebody walk across the room, that kind of thing. And physical therapy, all of these modalities, someone wants to see somebody who understands Parkinson's. Going to like an orthopedic physical therapist who doesn't know anything about Parkinson's, you're not really going to get the best outcome. So that's an important part of figuring out who you're seeing. I talked about the slowness of movement and your speech, and the slowness leads to smallness. Parkinson's wants to make people smaller. So people with Parkinson's need to do things bigger than they think they need to do. Speech is part of this. Speech can be impacted with Parkinson's. People's speech can get very low. There sometimes can be a stutter. There can sometimes be swallowing difficulties, drooling. So speech therapy can be very powerful in conserving speech and communication. And there are some specialized programs for people with Parkinson's to work on their speech. And the earlier, the better. Your voice, your tongue, your mouth, they're all muscles. They need to be worked. And so getting in and working with a professional can be very, very impactful. And then occupational therapy, which I call the most underutilized modality in Parkinson's. It is also challenging because there's not a lot of occupational therapists that I'm aware of who specialize in Parkinson's, but there is so much that occupational therapy can do to preserve quality of life and independence. Making slight adjustments, suggesting reorganizations of kitchens, those kind of things. Occupational therapists are really good at that. It'd be great if they knew Parkinson's, but even if they don't know Parkinson's, it's just a really great modality to help improve quality of life, which is what everything is about. So that's a little bit about rehab services. How are we doing on time? Okay, still good. Surgical treatments. So another approach to treating Parkinson's is through surgery. Currently, there are 2 approved methods. One is more common than the other. Deep brain stimulation is probably the most common thing. It is like a pacemaker for your brain. They implant these leads into a deep place in the person's brain, and it gives a small electrical current. And it's very effective on some of the motor symptoms of Parkinson's. And so this can be for people who they're getting some medication wearing off. Their medications are no longer as effective as they used to be. This can be a really great option. It's been around for over 20 years. It still has this idea of ooh, this is experimental. I have seen it be a game changer for the right candidate. I've seen people go in for their deep brain stimulation using a walker and a wheelchair to get around and come out once they have everything done, walking, boxing, doing yoga. It can really be impactful in a person's quality of life, but it has to be the right candidate. And they're very, very careful about picking who is the right candidate for this. The other surgical piece is this, it's called an infusion pump, and it delivers carbidopa-levodopa directly to the small intestine. So there's, a tube is put into the small intestine, and then it's delivered kind of like a feeding tube. So the medication does not have to cross the blood-brain barrier. It's not affected by what you eat and broken down or anything like that. So you get a lot more of your medication. I have also talked to patients who've done this, who it has given them back a lot of their life that they had lost, and a lot of their mobility. With both of these, they're both surgical treatments, and so there's risks involved to both of these, of course. So people have to assess where they are, their comfort level with that. There is also something at the FDA right now that is taking this idea of the carbidopa-levodopa infusion pump and making it more like a diabetes pump, which is subcutaneous. It goes right under the skin. And if this is approved, this could be pretty exciting because it's not a surgical thing, and you can pull the tube in and out yourself. Versus this it's just more complex, this infusion. So we'll see what happens with that. They're constantly making progress in better treatments. So that's really hopeful. Okay, that's all about Parkinson's. Let's talk about living well with Parkinson's. So besides the medical community, having a holistic approach to living with Parkinson's is really important. And this slide shows kind of all the pieces that are helpful in a person's life to live their best life with Parkinson's. And I'm going to go over some of this stuff. Exercise. Exercise is an essential part of living well with Parkinson's. Over the last decade, there's been a tremendous increase in the number of studies that demonstrate that exercise has great benefits in Parkinson's disease, including perhaps slowing down progression. They consistently reveal that people with Parkinson's can improve in their strength, their balance, their mobility, their flexibility. Exercise is also key in managing the non-motor symptoms of Parkinson's. It can help with sleep, it can help with fatigue, it can help with depression, it can help with anxiety, it can help with cognition. Exercise is really this like thing. And being sedentary and deconditioned leads to more rapid progression, increased stiffness. People get smaller, the stooped posture, not having endurance to move. So, so exercise is important. So over the years, there's been a number of Parkinson's specific exercise classes that are available to people. Many of them available virtually for free. But things like boxing and yoga and Tai Chi, cycling, even just walking, but really getting that recommendation of 150 minutes of moderate exercise or 75 minutes of vigorous exercise that's important. As Michael J. Fox once said in a talk that he did, he's like, do something every day that makes you pant. Like get your heart rate up, get moving. That is really helpful in a whole number of pieces. So exercise. Dietary considerations. Dietary protein can interfere with the absorption of levodopa. So people do need to be careful with their medication dosing and timing. You don't want to have a big steak dinner and take your Parkinson's medication at the same time, because both are amino acids and they will compete with one another. So you won't get as much of the medication into your brain. Constipation can be an issue. So having lots of fluids, eating fibrous foods, those kind of things. There is no one diet that is like, if you have Parkinson's, you have to eat this diet. But a Mediterranean lifestyle really is showing to have a lot more effects. There is some conversation about whether dairy is good or bad with Parkinson's, depending on what doctor you talk to. They may tell you don't do dairy or maybe limit dairy. So jury's still out on that, but just you want to eat to maximize your brain health, and real food, non-processed food, that kind of stuff is the best way to do that. So part of the team approach to Parkinson's, it is important. And so this strong team of the person with Parkinson's being in the middle, and then these wraparound services that support the entire team. APDA, our organization, is kind of on the outside of that. We are information and referrals. We help people with Parkinson's connect to all these different things. So we've talked a lot about sort of the medical bits of Parkinson's. There is a neurologist specialty called a movement disorder neurologist. that has undergone additional training in Parkinson's disease, who often give people the best management of their Parkinson's because they know the latest and greatest. But it is a neurologist that's really treats Parkinson's, and then pairing with the primary care physician and rehab services and things like that. Rehab services, keeping people's general health in check, community. So I'm going to talk about how APDA is part of that, and psychosocial support, counselors, friends, family, that kind of thing. So I will say community, which we are kind of a large part of, is developing this Parkinson's disease community. Seeking out support from friends, family, and community is an essential thing of this, which also you guys are about. You're building this community. A recent study of 1,500 people with Parkinson's disease. So they were surveyed, and in the study, they did all these variables and said, how well are you living? How fast do you feel like your Parkinson's is progressing? That kind of thing. The single strongest predictor of rapid Parkinson's disease progression was someone saying, I feel lonely. So friendship, not tremor, are really key to quality of life with Parkinson's. So building a community around. So staying connected to a community, whatever your community is, because Parkinson's can be kind of isolating. If someone has a tremor and go to a restaurant and they're tremoring while they're trying to eat soup and they're walking different and somebody thinks they're drunk and all those things, they can tend to isolate. And so we are helping fight that. Communities are helping fight that. We talk to people about that all the time. Don't isolate. Be involved in things. So APDA is kind of part of that. So I'm going to talk about who we are quickly because it's 9:43. These are always longer. So we were founded in the 60s. We are a very grassroots organization. We have just 4 staff. This says 3, but we just added Heidi. We serve 5 states. So our local chapter serves these 5 states. We are part of an umbrella organization that gives us a lot of expertise and national support and things like that. But what's beautiful about being this local chapter is we get to assess what are the local needs in the community, and we get to respond to that and work directly with the local community. And we really talk about providing this help for today and then hope for tomorrow through research. So I'm going to talk a little bit about all of those things. So what do? Support, resources, education, and research. Those are kind of the 4 main things. We are a telephone, hotline, and referral center. We answer the phone. We answer our email. I give referrals to healthcare providers, support groups, exercises. We offer a sympathetic ear. I talked to a lady just on Tuesday, I guess it was. I talked to her for almost an hour. She was in tears when she called. She didn't know where to turn. Her husband of 55 had just been diagnosed with Parkinson's, and she was freaking out. And so we had a conversation because they didn't give you information. They didn't give her information. Oh, he has Parkinson's. And she's like, what does that mean? And so, she called us. I told her about other people living with Parkinson's. I said, yeah, it's going to suck, but there's also all this stuff that is out there for you, and we will get you connected. So that's an important lifeline for people. We believe in the power of support groups. Getting together with people who truly, in a safe space, who truly understand what you're going through, can relate, can be very powerful. So we run some professionally led support groups, as well as provide assistance to all the community support groups that are in our 5-state region through resources, through ideas for special guests, those kind of things. We run a program for newly diagnosed. It is an 8-week psychosocial support program that is part education and it's part a time to just talk. So it's small, it's facilitated. We have a subject every week. The idea is people meet others, they learn about folks early on in their disease. And so as they're living with Parkinson's, if something bubbles up, they feel supported, they feel empowered to figure it out, and won't go down into that loneliness, depression place, hopefully. So we give them these tools through this 8-week program. We also have a financial support program. And it was designed for those who maybe are struggling financially to use this money to increase quality of life. So they may use it to pay for exercise programs. They may use it to pay for medication copays. They may use it to hire the neighbor kid to mow their lawn. So it's really just here's a check, use it for whatever will improve your quality of life. We're actually, we had a good fundraising year last year, so we have increased that funding to $400 come January. So we're excited to be able to give people just a little bit of financial boost, because Parkinson's can be very expensive. We provide community grants to Parkinson disease exercise classes. We have contracted with some really great fitness professionals to do free virtual classes. So we have a weekly dance class. We have a twice-a-week yoga class. We have a once-a-week high energy intensity training kind of class that people can just sign into Zoom and do from the comfort of their own home. And then there's other chapters around the country that are doing things. We are an information and referral center. We have about 40 publications. We have a handbook, we have an exercise book, we have a speech book. We have pamphlets on different things that can happen with Parkinson's. They are all available to be mailed to people for free, or they can download them on our website. They are written by experts in the field, so they are great, reliable information about living with Parkinson's and what you can do. We do a quarterly newsletter that we produce locally. It's a really fantastic publication. And we send that out to people with Parkinson's and families, anybody on our mailing list. We email it out. We put it in doctor's offices so people can find out about us. I get a lot of calls. I saw this in my doctor's office. How do I get one at my house? So they get on our mailing list and we send that out. And it's got, interesting articles, and it's very locally focused. So it's Northwest focused. We truly believe that the more educated you are about Parkinson's, it's kind of a complex disorder. The more empowered you can be in taking control over those things that bubble up and happen. So we execute a number of education programs throughout the year. We have a program called Take Control. It's about every other month. We do it virtually. We invite experts in to talk about different things. We've done palliative care. We've done end-of-life issues. We've done sleep issues, pain in Parkinson's. So it's a variety of different subjects. We have an educational program strictly for those newly diagnosed that just goes over like the basics of living with Parkinson's. It's kind of like drinking from a fire hose, because you're getting just thrown all this information at you, but it's really important to know this information as you're going to be living with this condition. And then we do a support group leader training. We have a variety of webinars. Really, the goal is to educate and raise awareness so that patient care can be improved, whether it's self-empowerment or whether it's a medical professional who wants to care for Parkinson's patients better. And we fund research. So APDA over the years has invested these numbers are actually off. It's more than that. Throughout, and we really focus, we are grassroots. We don't have the giant dollars like the Michael J. Fox Foundation, who's very involved in research. They have $1 million research grants that they send out. We don't have that kind of money. We're very grassroots. But what we do believe in is the up and coming researchers. So the younger people in their field who have really, really promising ideas, we fund their research. They apply for grants. And then a lot of those people have gone on to leverage those proof of concept things in research. And they have leveraged it to get bigger grants from like the National Institutes of Health or Michael J. Fox or other bigger funders in the research field. So we've been involved in almost every Parkinson's disease breakthrough since our inception in 1961. So involved at some level, which is really great because those young researchers need that support. And then we as a local chapter, we fund this thing called the Washington State Parkinson Disease Registry. It is like the Match.com of Parkinson's research. So a researcher who is doing research can apply to the registry to query this database of people who have said, yeah, I would participate in research if it was the right project. So they can sign up to be in this database. And then a researcher can query the database to find people that might participate in their research project. So it speeds up the process of research because 80% or more of research projects fail because they don't have enough participants. So this is speeding up that process and finding people interested. So we fund that fully so they can keep it going. We don't get government funding. It's all through fundraisers. We just had our optimism walk where people got together and walked and raised money. We do a gala every year in March. Individuals may put together different fundraisers. Individual contributions are huge. We get sponsorship dollars from people. We try to get them involved in what we're doing. But that's how we fund the work that we do and the help that we do in the community. So, and we, like I said, we had a good year last year. So we were able to raise our financial support scholarship by $100. So individuals can get a little bit more assistance. So that's pretty exciting. How can you be involved? You just invited us to speak, raising awareness, sharing your time and talent, donating, all of those things. We are lean and mean. We have 4 people for 5 states. And we're really trying to make sure that people know of the resources available. If they're living with Parkinson's, we want them to be connected so they know, hey, there's a community out there and there's resources available. So that is that. If I could move my mouse. There you go. So,
wow, Jen, that was an amazing amount of information. Thank you.
Yes.
I'm sure other people I have some questions. I'm sure other folks do too. So let's,
please, yes.
We have some more time. So let's open it up for some questions.
Yes, Paul.
Yeah, Paul.
Yeah, I'm a man with Parkinson's, and I'm not familiar with your organizations, but I have consulted a bit with the Michael Fox, but more than that with the Parkinson's Foundation, and it sounds like there's a lot of the same services and goals and objectives between. Is there something that you fit well with the foundation? How does that work?
As far as how we interact with like the Michael J. Fox Foundation and other Parkinson's organizations?
Yeah, the Parkinson's Foundation has been a source for speech and things like that.
I will say that there are it's interesting because I've been in medical nonprofit for a long time, and the Parkinson's disease realm has a lot of nonprofits that are working, and they all have very similar, a little bit of similar goals and a little bit of similar missions. So it's really interesting. The good thing about that is that there's a lot of resources out there and there's a lot of information. The bad thing about that is it's super confusing because there's all where do I get this information? So for me, for us, we are very locally focused. So we have these national things that we're able to access and do, but we're really about assessing the needs of the local community. So I'm very aware of who the doctors are, where the support groups are, where the exercise programs are, helping people, implement that and answering the phone on a local level. And what I often say to people is, whomever you feel like you're getting the support and information that you need, then that's, I guess, who your affinity is towards. And it can be multiple organizations. And we all do work together kind of at a national advocacy level. That's how some of the legislation has come through. So we are very collaborative in this, like really wanting to push, you know, better funding for research and better and services for people with Parkinson's. So I don't know if that answers that question.
Yeah, somewhat. And, you know, I think I'm going to follow up with the registering with the research projects that interests me.
Okay, great. Yeah. Yeah.
Jen, where would people go, like to get onto your mailing list or to, are the press program or the, you know, some of the support groups, are those online or
some of the, yeah.
How do people get connected with these
Yeah. So the pandemic was we've always covered 5 states, but with in-person programming, because, you know, we had 3 staff at that point, we couldn't get all over to our 5 states all the time. And we've done programs like in Spokane and in Anchorage and things like that. But these virtual programs are here to stay and continue. We do a weekly like email newsletter that talks about the things that are going on. So if people get into our database, they'll get the newsletter, they'll get that notification. And then if they see, oh, a new press program is starting, or, hey, I really am interested in this subject for this Take Control program, I'll go ahead and sign up for it. So they can, you know, they can go to our website, they can email me. I can put it in the chat, but I'll put our email address in there. Our general email. Did I spell it right? Yes. And then our website, I'll type in there. And those are both really great resources just to find good, reliable information. I mean, I think that's the importance of these Parkinson's organizations is Dr. Google can be super confusing. So going to a good, reliable source who you know has vetted, scientifically proven information can, and you know, getting those resources is important, I think. Yeah.
Great.
Did I spell things right?
Fantastic.
Yeah, Elizabeth.
And then,
oh yeah, go ahead.
Yeah, go ahead, Betsy.
So you're speaking to a population that sort of at baseline tends to be super active and very engaged with the outdoors. Paul has been a super athlete his whole life, which I think has really set him up for a lot of success in dealing with the illness. But I'm curious about your exercise programs. How are they? Are they programs that sort of speak to a broad range of people's state of being, or do you target at different levels of disability? How does that work?
It depends on the program. I can, like our dance program that's every Sunday. It's really awesome. It's run by a dancer who is living with Parkinson's. So he's been a dancer his whole life and he's also living with Parkinson's. And it starts in a chair. So it can be done by people who maybe aren't standing a lot. So, and then he moves to standing, but he caters it. So if you want to stay in the chair, so you can stay in the chair or you can stand and you can participate in this class. And so, and he, all the instructors who are contracted with us to do our classes have knowledge of Parkinson's. And so they know the exercise fundamentals of what is going to benefit somebody with Parkinson's. So, so that's like the dance class. The yoga class is very much the same way. Our Monday class, which is the high intensity one, that's more for someone who wants to really sweat a lot and, you know, is more high intensity. So it really varies on the class.
Okay.
Yeah.
And the same with I gather there's some support groups, affinity groups, that you run. Do those have facilitators do you have them both for family and for people who with the illness, or?
Yeah, so there are support groups specifically for care partners. In fact, I also forgot to mention, we run a 6-week Powerful Tools for Caregivers series. And we run that specifically for caregivers of people with Parkinson's. But so there are support groups. There's that program, but there's also support groups that are just for caregivers. There are support groups. We run one called Flying Solo with Parkinson's, which is for people who don't have care partners. So they're either widowed or single or living by themselves. There's a young onset Parkinson's group. And then there are general groups, which are generally open to the person with Parkinson's and their care partner. And each group, of course, has their own kind of culture. Some of them skew, you know, more active, some of them skew less active. It really depends. So and it depends on the community. So some are online and some are specifically in a certain community. And then I also help people, like if you guys wanted to start a support group in your area, I can help whoever wants to kind of facilitate that group with tools and resources. And I have a support group leader manual and things like that.
Okay.
Yeah.
Thank you.
Yeah, thank you. Great questions, everybody. One last thing. Do you remember do you know the name of the legislation that's up, and is it in the Senate or the House? And do we call our rep, or who do we contact to say we want to see that supported?
That is a great question. Let me go just a sec. My other screen. Oh, I don't want Zoom. I want APDA's website. I think it's still up on the front page. It is called, is it still up here? No, you took it down. It's called Ending Legislation. What is it called? It's like Ending Parkinson's Disease, or it's called the National Plan to End Parkinson's. So I will put this in the chat and you can click on it and it'll open up in a tab. So this will tell you about it. It was introduced in the US House on July 28th, and it was introduced in the Senate on September 15th, and it's bipartisan. Go figure. Something bipartisan. It's a good thing. So yeah, so talking to your legislators, the more support. The thing is, people with Parkinson's, this is my advocacy hat going on. We've been too quiet. No, it's been kind of this disease that's kind of been under the radar. It hasn't gotten a lot of the noise that, like, Alzheimer's is a devastating condition. It's gotten a lot of funding, and there's a lot of people who have been noisy about Alzheimer's. This is how HIV treatments came through. That community got super noisy. So it's time, in my opinion, for Parkinson's disease, people who are living or impacted by Parkinson's, to get noisier. So, you know, and I'll also, this is an awesome thing. I'm going to put that in the chat too. Oops. There's this thing that started in the pandemic, and it's made up of people. I'm not sure if it's .com or .org, but they're called PD Avengers. And they are really pulling together a collaboration of people across the world who are living with Parkinson's disease to get louder, to have resources in developing countries as well. Like, and it's super inspirational. Every time I go to a meeting with them, I'm like, oh my gosh, there's really cool stuff going on. And they're trying to get 1 million Avengers to join their ranks. So you should go on and check them out and maybe become an Avenger. So, yeah.
Okay, well, we are past 10 o'clock, so
Yes.
10:06, we run over. So thank you so much, everyone, for your time. And it's great that this has been recorded, and I know that we'll be passing on these resources and banking them in our
Thank you for having me,
library.
and do feel free to reach out if you have questions or want to connect with us. I'm available. You guys know how to get a hold of me, at least Betsy and you all do. So yeah.
And
so
I
take
would
care.
just say, if any of you in the room are interested in some other aspect of this discussion, please get back to either me or Tracy about it, with feedback or your thoughts about how we could carry a conversation forward.
Yeah.
And really, thank you so much for joining us, Jen.
You are welcome, and I hope you all have a wonderful weekend. I mean, it's going to be weird that I'm going to say, I hope we get some rain soon.
Yeah, no, that's not weird.
Yeah. That's
true.
All right. Take care,
okay.
everyone.
Thanks
Bye-bye.
so much.